Open-angle glaucoma is a type of glaucoma in which there is no detected mechanical narrowing or closing of the anterior chamber, right? Specifically, we're talking about the iridocorneal angle, right? In this case, it will be open, right? So the causes of this condition are in most cases are unknown, right? So it's known as primary open-angle glaucoma. If we know the causes, we call it secondary open-angle glaucoma. Simple, right? So by definition, primary open-angle glaucoma is a syndrome of optic nerve damage associated with an open anterior chamber angle and an elevated or sometimes average intraocular pressure, right? In this case, both eyes are usually affected, but typically not equally. This is very important because this is what is responsible for delay in recognition of this glaucoma. So look at this. This is just how to differentiate between open angle glaucoma and closed angle glaucoma, right? So in open angle, you can see it here, right? So the aqueous humor produced by the ciliary body goes to the posterior angle and then anterior angle. So you see this angle is open, thus open angle glaucoma. In closed angle glaucoma or angle closure glaucoma, you see that the angle is closed, right? Okay, let's talk about some risk factors, right? So risk factors for primary open angle glaucoma include the following. Firstly, older age. So older age is very important. Other risk factors include positive family history, African ethnicity, very important, thinner central corneal thickness, systemic hypertension, diabetes, very important, myopia, right? So, in people of African ethnicity, glaucoma is more severe and it develops at an earlier age, right? In addition to that, blindness is 6 to 8 times more likely in people of African ethnicity. Right, so let's talk about the pathophysiology of primary open angle glaucoma. Right, in primary open angle glaucoma, there is an abnormality of extracellular matrix in the part of the trabecular meshwork that is immediately adjacent to the sclem canal called the juxtacanalicular trabecular meshwork. Right, so similar to what accelerated aging. In this case, trabecular meshwork cellularity may also decrease. So as I told you in the previous video, in glaucoma, the intraocular pressure can be elevated, thus elevated pressure glaucoma, or can be normal, thus normal pressure glaucoma, right? Okay, so let's start with the elevated pressure glaucoma. 2/3 of patients with glaucoma have elevated intraocular pressure of more than 21 millimeters of mercury. In this case, the aqueous humor drainage is inadequate, whereas the production by the ciliary body is normal. Identifiable mechanisms, thus secondary open-angle glaucomas, are not present, right? I told you we don't know the exact cause, right? And what are the examples of secondary mechanisms? Right? So these include developmental anomalies, scarring caused by trauma or infection, plugging of channels by detached iris pigment, thus pigment dispersion syndrome, or abnormal protein deposits, thus pseudoexfoliation syndrome. We have a separate video of secondary glaucoma, so don't worry about that. Right. That's elevated pressure glaucoma. Now, normal pressure glaucoma or low tension or low pressure glaucoma, a lot of names, right? In at least 1/3 of patients with glaucoma, the intraocular pressure is within the average range, but the optic nerve damage and visual field loss typical of glaucoma are present. These patients have a higher incidence of vasospastic diseases, for example, migraines or Raynaud syndrome, than the general population, suggesting that the vascular disorder compromising the blood flow to the optic nerve may play a role in this glaucoma. Glaucoma occurring with the average range intraocular pressure is more common among Asians. Right, so I told you that the exact cause is unknown, but the pathophysiological mechanisms which have been implicated include mechanical, vascular, metabolic, and apoptotic. Right, starting with the mechanical mechanisms. The mechanical mechanisms is associated with disturbance of normal function of the eye drainage system due to clogging of the drainage canals or narrowing of the intratrabecular spaces with aging or as a result of other eye or systemic conditions or traumas. As a consequence, the aqueous fluid does not drain from the eye properly, and this causes the steady increase of the intraocular pressure. Number 2, the disorders of the vascular system, right? So these disorders have been implicated in the development of primary open-angle glaucoma. There may be a deficit in the rate of blood flow in the intraocular circulation, including retinal, central retinal artery, optic nerve head circulation, etc. Right. On number 4, we have metabolic mechanism, and the main culprit is nitric oxide. Right. So the main biological effect of nitric oxide is regulation of the microcirculatory blood pressure to the inner layers and optic nerve discs, coordination of transport through the aqueous humor drainage system, and participation in the mechanism of neuronal apoptosis, which brings us to the last mechanism, which is the apoptotic theory. Right. So this theory states that the genetically programmed destruction of retinal ganglion cells may play a role in the glaucoma pathogenesis. Okay, moving on to signs and symptoms of primary open-angle glaucoma. Right, so I told you there is a late recognition of this condition. So in early stages, the symptoms are uncommon. It's very rare to have these symptoms. In most cases, the patient becomes aware of the visual field loss when the optic nerve atrophy is marked, right? The typically asymmetric deficits contributes to the delay in the recognition, right? So that's what I told you in the beginning. However, some patients have complaints such as missing stairs, their inferior visual fields has been lost. Noticing portions of words missing when reading, or having difficulty with driving earlier in the course of this disease. Examination findings include an obstructed open angle on gonioscopy and characteristic optic nerve appearance and visual field defects, right? So we will talk about these. It's very important. Okay. The intraocular pressure may be normal or high, but is almost always high in the eye with more optic nerve damage, right? So what's the typical appearance of the optic nerve, right? Okay, so it looks like this. The optic nerve is normally a slightly vertical elongated circle, right, or a disc. with a centrally located cup, right? A depression here, right? And there is a neuroretinal rim. The neuroretinal rim is the tissue between the cup and the disc margins, right? So this is the depression we call the cup and the disc margin. And in between here, that's where you find the neuroretinal rim, right? Okay, so what are the characteristics usually in glaucoma, right? There will be increased cup disc ratio, particularly an increased ratio over time, right? So if you perform ophthalmoscopy again and again, you will see over time there will be an increase in this ratio. Thinning of the neurosensory rim, pitting or notching of the rim, nerve fiber layer hemorrhage that crosses the disc margin. It's called Drans hemorrhage or splinter hemorrhages. I have a very good picture I will show you in just a moment. There will also be vertical elongation of the cup, quick angulations in the course of the exiting blood vessels called bionetting. Right, okay, so here on the first image here, you are looking at the moderate glaucoma. All right, so this image shows thinning of the neuroretinal rim with an increased cup disc ratio, pitting or notching of the rim, and wedge-shaped dark areas that reflect retinal nerve fiber layer damage. In the second image here is advanced glaucoma, and this image shows signs of advanced glaucoma include marked enlargement of the cup. Is called total cupping, right? So you see this cup, like the central locate, it is enlarged to the extent that the neuroretinal rim is very thin, and peripapillary atrophy mimicking the neuroretinal rim. And last here, here you can see optic disc hemorrhage, right? So this photo shows Drans or splinter hemorrhage. So if you look at 4 o'clock, you see it here, this hemorrhage that crosses the optic disc margin, right? Okay. What about the visual fields? I mentioned them. They are very important, right? So the visual field changes caused by the lesions of the optic nerve includes the following: the nasal step defects, which do not cross the horizontal meridian. The horizontal meridian. Right, so the horizontal meridian is an imaginary horizontal line between the upper and lower parts of the visual fields. The aqueous scotoma or arc-shaped scotoma extending nasally from the blind spot, and temporal wedge defects, paracentral scotoma, right? So these are the most common features in visual fields, right? So in contrast, the deficits of the more proximal visual pathways, that is from the lateral geniculate to the lateral geniculate nucleus to the occipital nerve, will involve quadrants or hemispheres of the visual fields. Thus, the visual fields, the deficits do not cross the vertical meridian, right? So in this glaucoma, they do not cross the horizontal meridian, and here they do not cross the vertical meridian. Right, so according to what I just explained, now I'm sure you have figured out what diagnosis of glaucoma, right? So we use visual field testing, ophthalmoscopy, measurement of central corneal thickness and intraocular pressure, and exclusion of other optic neuropathies. Diagnosis of primary open-angle glaucoma is suggested by the examination, like using the above-mentioned methods, but similar findings can also result from other optic neuropathies. That's where you need perfect differential diagnosis. For example, if the neuropathies are caused by ischemia, cytomegalovirus infection, or even vitamin B12 deficiency. Right. So before a diagnosis of normal pressure glaucoma can be established, the following factors may need to be ruled out first. Right. So inaccurate intraocular pressure readings, right? You need to rule out that. Large diurnal fluctuations causing the intermittent normal readings. Optic nerve damage caused by previously resolved glaucoma, for example, a previously elevated intraocular pressure due to corticosteroid use or uveitis. Intermittent angle closure glaucoma, we'll talk about it later in the other video, and other ocular or neurologic disorders that cause similar visual field defects, right? So this is what you need to rule out first. The central corneal thickness is measured to help interpret the results of the intraocular pressure, because as I said in the previous video, the thickness contributes to the measurement of pressure, right? Okay, you can click the link on the top right corner and watch that video. It's very important. Okay, what about treatment of primary open angle glaucoma, right? So there are three main methods: medical treatment, laser, and surgery, right? Starting with the medical treatment, right? So the main aim here is to reduce the intraocular pressure, right? So firstly, hypotensive, decreasing and stabilization of the intraocular pressure. Right, so we can do this by improving the aqueous humor outflow through the trabecular or uveoscleral pathways, right? And the other way is suppression of the aqueous humor production. Protection of the optic nerve fibers from damage caused by the disease, right? That's the correction of the trophic and circulatory disorders, right? Okay, so let's start with the medical treatment, right? So in medical treatment, the medications are divided into two groups: the medications of first choice and second choice, right? Okay, so the first choice medications include the following: the non-selective beta blockers like timolol, right? And this is administered 2 times a day. The other first choice is prostaglandin analogs, for example, latanoprost, trovaprost, tafloprost, bimatoprost, right? So this is given once a day, right? So in case of the lack of effectiveness of this therapy, we go to the second choice, right? So what are the usual drugs used as a second choice? So this includes selective beta blockers like betaxolol, which is given twice a day, carbonic anhydrase inhibitors like dozolamide, brinzolamide, which is given 2 to 3 times a day. The next, selective alpha adrenergic agonists like brimonidine, which is given 2 times a day. And lastly, miotic or cholinergic agents like pilocarpine, which is given like 4 times a day, right? There are also other preparations called combined preparations, right? So the combined preparations, these are some of the examples: dozolamide plus timolol, brinzolamide plus timolol, latanoprost plus timolol, travoprost plus timolol, brimatoprost plus timolol, pilocarpine plus timolol, brimonidine plus timolol. So these are just the drugs which I mentioned previously, but now we are just combining them, right? Okay. Another class I told you, neuroprotective agents, right? So here include antioxidants, neuropeptides, calcium channel blockers like nifedipine, verapamil, vasoprotectives, nootropic agents, and antisclerotic preparations, vitamins and minerals also included under neuroprotective, right? But if this medical treatment doesn't work, we go to the next, laser, right? Use of laser. So the main ones are argon laser trabeculoplasty or ALT, and the second one is selective laser trabeculoplasty or SLT, right? So in argon laser trabeculoplasty, this is a hot laser used to create tiny burns on the trabecular meshwork, which causes scarring, the formation of scars of the tissue, resulting in stretching and then opening of the adjacent trabecular pores, and thus improving the aqueous humor outflow from the eye. Right? That's argon laser, hot. The second one, selective laser trabeculoplasty. This one is actually it uses a pulsed double frequency neodymium yttrium aluminium garnet laser, right? So this is actually a cold laser, right? A cold laser with relatively low power used to selectively target specific cells like melanocytes within the trabecular meshwork. Another method which is rarely used, but it's actually like a last option, right? It's called what? Cyclophosphocoagulation, and this involves application of the laser bands to the ciliary body, which causes destruction of the processes tissues, reducing the aqueous humor production, right? Okay. And if the lasers doesn't produce like desired results, then we go to surgery, right? So the method we can use firstly is called a guided filtration procedure, right? So this is the most commonly used filtration procedure. In this case, a hole is made in the limbal sclera called trabeculectomy, which is covered by a partial thickness scleral flap that controls egress of aqueous from the eye to the subconjunctival space, forming a filtration bleb, right? A bleb is like a blister. Adverse effects of glaucoma filtration surgery include acceleration of cataract growth, pressures that are too low, transient accumulation of fluid in the choroidal space, thus choroidal effusion during the perioperative period. Patients with trabeculectomies are at risk of bacterial endophthalmitis and should be instructed to report any symptoms of signs of bleb infections, thus blebitis or endophthalmitis, for example, worsening vision, conjunctival hyperemia, pain, right? So this they should report immediately so that the ophthalmologist can have a look, right? Okay. And the second methods is partial thickness procedures. Partial thickness procedures bypass portions of the outflow pathways. Unlike full thickness procedures, even if guarded, that create a direct conduit between the anterior chamber and the subconjunctival space, right? So there are two methods. It's called what? Ab external and ab internal approach. The ab external approach, that's the approach from the outside of the eye, including viscocanalostomy, deep sclerectomy, and canaloplasty, involve a deep dissection greater than like 90% thickness of the scleral passage leaving a window of Descemet membrane and or the inner wall of the sclem canal and trabecular meshwork. This canal is then dilated by using viscoelastic solution that's called viscocanalostomy, or a microcatheter, it's called canaloplasty. Deep sclerectomy generally relies on formation of the conjunctival bleb. Right, and the next one is ab interno. Ab interno approach, that's the approach from the inside of the eye. A device is used to remove or bypass the trabecular meshwork. Right, so to remove is that's with ab interno trabeculectomy or bypass. Bypass here is used like we do using a stent, right? Some stent procedures, creating a direct communication between the anterior chamber and the collecting channels, right? So the most important thing is that in ab interno, in the approach from the inside, there is no risk of a bleb formation, no bleb formation. So it's actually very cool. So risk of infections are very low in ab interno. Thank you so much. If you like this video, please make sure you subscribe, leave a comment in the comment section, and until next time.